Hello and welcome to the second in our series of videos on airway pressure release ventilation. This time we're going to cover practice. We're going to look briefly at which patients may well benefit from airway pressure release ventilation. We'll look at how you should set it up, how in particular you set T low, because that's quite critical. We'll look at how you titrate your APRV settings to your ABG results. We'll look at weaning patients away from APRV, and we'll also look at the potential risks to your patient from using this mode of ventilation. So, which patients may benefit from using airway pressure release ventilation? Well, it's true to say that some centres do use it as their main mode of ventilation for patients, but more commonly, and certainly where I work, it's used as a rescue for patients with severe hypoxemic respiratory failure. Anecdotally, what we have found over the years is that people with homogeneous lung disease, such as viral pneumonitis or pancreatitis or ARDS, do seem to benefit. Those with fluid overload, the obese, and other patients who are at great risk of atelectasis. And we've also used it as a rescue in patients where we've not been able to turn them prone, such as patients with spinal injuries, for example. So how do you set APRV up for your patient then? Well, the number one thing you must do is have a sound understanding of your ventilator, how it works, and how the various terminology for different modes of ventilation may vary depending on who makes your ventilator. Once you've done that, take a note of your current settings. If APRV isn't working for your patient, you need to know what you're going to go back to. Then take a note of your current mean airway pressure on the ventilator, and then ensure that the view you have on the screen of your ventilator allows you to see inspiratory and expiratory flow versus time graphs. Then switch to APRV. In terms of initial settings, I'll go through them in order, but I would suggest that your P high should be above the previously noted mean airway pressure. Typically values of 20 to 30, more often leaning towards 30 centimeters of water, are appropriate starting points for most patients. P low or PEEP, depending on which mode of ventilator you've got, should be between 0 and 5 centimeters of water. T high, I would plump for approximately 5 seconds initially, and your T low or T at PEEP should be less than 1 second, but that's going to need immediate titration. So how do you go about setting T low? A P low of 0 does not mean that pressure within the lungs is ever actually going to equate with atmospheric pressure. The end expiratory lung volume, that volume present within the lungs just before the ventilator cycles back into inspiration or to P high, is maintained by having a very short expiratory phase, a short T low. T low should be set to cycle back to P high when the expiratory flow rate is 50 to 75% of the peak expiratory flow rate. So what does that actually mean? Well, this is why you need a flow, inspiratory and expiratory flow versus time graph on your screen. Have a look at the expiratory phase here in brown. We have set the ventilator, we've set T low on this ventilator to 0.4 seconds. And that is approximately the point at which expiratory flow is 75% of its peak. That's the point we're cycling back to high pressure. That's what's preventing atelectasis. Be aware that when you look at some of the delivered values on the ventilator in APRV, they may be much higher than you would typically aim for, in particular tidal volumes. Seeing values of 8 to 10 mils per kilo ideal body weight are not unusual with APRV, but it is contrary to established teaching on lung protective or low tidal volume ventilation. So far, such high tidal volume has not been shown to be harmful, and in fact some animal models where they've looked at inflammatory markers within the lungs found lower levels of inflammatory markers within the lungs of patients ventilated with APRV, even with these high tidal volumes, than when compared with lower tidal volume ventilation. So how do you titrate your APRV settings to your arterial blood gas results? Well, pick some targets to start with. I would typically, for people with hypoxemic respiratory failure needing airway pressure release ventilation, I would typically be targeting an arterial oxygen saturation of 88 to 92%. There may be circumstances where you want to aim higher than that, and indeed there may be some where you're accepting lower than that, but have a reasonable target. With regard to carbon dioxide, permissive hypercapnia is part and parcel of APRV, just as it is with low tidal volume ventilation. Clearly not in certain circumstances though, such as pregnancy or traumatic brain injury. What we're really interested in is not the CO2 most of the time, it's the pH. And you want to keep the patient away from an acidotic state, away from a state that could cause problems with cardiac arrhythmias, for example. So in terms of oxygenation, if you're overachieving, reduce your FiO2. But once FiO2 is getting down to approximately 40%, I would start at that point to reduce P high, reducing it by approximately 2 centimeters of water every 4 to 6 hours or so, and then reviewing the next set of blood gases, just taking things slowly and gently. If hypoxemia is still a problem for you, I would increase P high. Increasing P high will hopefully maximize alveolar recruitment, minimize dead space, maximize a gas exchange area. The next thing I would do would be thinking about increasing my T high, so giving more time per minute at high pressure compared with low pressure. I would also consider reducing T low, again to maximize time at high pressure and maximize lung recruitment, and clearly I would increase the fraction of inspired oxygen concentration as well. For carbon dioxide then, I would tolerate hypercapnia unless your pH is getting into that acidotic range or you've got a pregnant patient or a patient with a head injury. I would make sure that my patient is able to breathe spontaneously. Have we been bolusing sedation and rendering them apneic? I would also then check my ventilator circuit is free from excessive secretions. The heat and moisture exchange filter is a classic place for getting clogged up. I would then look to reduce T high by 0.2 seconds. This gives more time over a minute at T low, therefore more time to get CO2 out of the patient. I would also consider increasing my P high again, because that may help maximize recruitment and minimize dead space, maximize the area of lung working to get carbon dioxide away from your patient. If CO2 is low, well, firstly, I would check the cardiac output from my patient is adequate. I would then look to increase T high by 0.2 of a second. So again, we're looking at more time now at high pressure than low. And I would consider reducing my P high slightly, which means the difference between P high and P low is less, potentially a lower tidal volume as a result, and that will potentially help your patient blow off a little bit less in the way of CO2, if that's becoming a problem for you. So how do you wean patients away from APRV then? Well, I would follow what we've talked about already with regards to titration to ABG results. Once I get to a P high of around about 20 centimeters of water, I would start to increase T high. I would keep my patient breathing spontaneously, and as T high gets longer and longer, you're essentially weaning your patient onto CPAP. At that point, if your patient's ready for a trial of extubation, that could be the time to go for it. Alternatively, you could switch to a more conventional mode of ventilation, such as CPAP with assisted spontaneous breathing. I would set CPAP to be at the level of my last P high with a small amount of assist, perhaps 5 or 6 centimeters of water assist. So what are the risks then? Well, we've talked about high tidal volumes being a particular risk potentially for respiratory patients. I'd be very cautious of using APRV with these high volumes in people with recent lung surgery, for example, or severe emphysematous lung disease. Also, you've got to understand that APRV doesn't necessarily completely eliminate atelectasis, so atelectasis is still a possibility with APRV. Within the cardiovascular system, it's pretty clear that such high intrathoracic pressure sustained for such a long period throughout the respiratory cycle may lead to a reduced venous return and cardiac output. This is particularly a problem if you've got a patient with right ventricular problems or pulmonary hypertension problems. I would avoid using APRV in under-resuscitated patients, but bear in mind that some of the biggest case series we have for APRV are in trauma patients. So a well-resuscitated trauma patient is not a contraindication to using airway pressure release ventilation. I have frequently found that as a result of using less sedatives and less muscle relaxants, we are often able to reduce the doses of cardiovascular support for patients on APRV. We're trying to get them breathing spontaneously, we're weaning the sedatives down, we're stopping the muscle relaxants, and these patients often need less blood pressure support. If I do run into a problem with hypotension, typically a small fluid bolus of 250 to 500 mils will often get you through that. Within neurocritical care, we do have to recognise that these high intrathoracic pressures may well impair venous drainage from the head, which potentially could raise intracranial pressure. There aren't any large data sets out there of APRV in traumatic brain injury. I can tell you that my local experience using APRV in traumatic brain injury patients with intracranial pressure monitoring, I don't see big changes in ICP when switching patients onto APRV. And because avoidance of hypoxemia is so key in neurocritical care, I've often found that if I correct the hypoxemia, the ICP actually improves. I do have to pay close attention to CO2 in these patients though. Permissive hypercapnia in traumatic brain injury is not an appropriate thing to be doing. So with this second talk then, we've looked through how to initiate APRV for your patient, how to titrate settings to your blood gas results. We've looked at weaning away from APRV back to conventional ventilation or indeed extubation, and we've looked at some of the risks that may be associated with APRV and how you can troubleshoot them. I hope you found this video useful. If you do have any questions or comments, please leave them down below, and I hope to see you on the next one.